Welcome to the Studio Talk podcast. I'm Xiomara Sosa, your co-host. Every week, we speak to our community members to teach them about mental health through education and awareness, and our hope is to inspire them through social change advocacy. We also interview community members and other mental health professionals, clinicians, healers, students, and wellness professionals. Our style is storytelling. Everyone has a mental health story to tell. The information shared in this podcast is not a substitute for seeking help from a licensed mental health professional and is not a substitute for psychological diagnosis or treatment. It's purely educational and purely social change advocacy. If you find yourself in any sort of mental health emergency or distress, please dial 911 or go to your nearest emergency room. Hello everyone and welcome to the Studio Talk. This is Xiomara and I am a clinical mental health counselor located here in Somerville, South Carolina.
And I'm Victoria. I'm a licensed professional counselor in Somerville, South Carolina as well.
One of the things that we wanted to sort of introduce to everyone first was the question of why are we having this podcast to begin with? And so we're just going to get right into that and try to cover that first. And then we'll start talking about our topic. And our topic is going to be for today, for this episode, what is mental health? What is mental illness? Is there a difference? And what is the difference?
Yeah, so I think Xiomara and I came up with this idea to start a podcast. Actually, I have to give you the credit here because you're the one who came up with the idea to have a podcast about mental health, just because even though there are podcasts about mental health, I don't think there's a lot that we've really resonated with or that we really enjoyed listening to, per se. And also, I think sometimes these mental health podcasts stay, I don't want to say surface level, but they're not really encompassing all of mental health in my my mind.
They're very niche or niche.
Yeah,
niche.
However you say it.
Yeah.
But yeah, so I would love to have a podcast or some kind of platform to talk about just any topic about mental health. Like that's a big thing with me is I don't want any topic to be off limits in this podcast.
So yeah, and for me, one of the reasons, I've been thinking about doing a podcast like this forever, and I always knew it would be different because I really didn't want anything to be clinical. I didn't want it to come off as if we were sitting here being very clinical, very judgy about people and trying to kind of just throw information at everyone and make them feel like we're diagnosing them and we're telling them what to do. That's really not what this podcast is about. What this podcast is about is really about us talking to our community members, talking to colleagues, having people who are experts in some areas come in and sort of demystify information that has to do with mental health. And this topic for our first episode is really important because people really do this interchange. They interchange the word, the concept of mental health and mental illness. And so in general, people really don't understand what the difference is and why it's important, because it's very important to understand the difference between the two. And so our whole thing is to have a very laid back, down to earth conversation, like you're at home with your sisters, with your friends, having a regular conversation about topics that people really don't talk about when it has to do with mental health and mental illness. So that's what we are. Yeah.
And I think my friends and family are just tired of listening to me talk about mental health, so I just wanted an outlet for myself for selfish reasons, I guess. So yeah, I'm definitely excited about it.
Yeah, and just to remind our listeners that both Victoria and I have our own solo practices, which we sort of are under this umbrella of a cooperative that, there's this vision that I have about. But really, for us, we deal with this every day. This is our career. And so that we don't want to come to the podcast and feel like it's an extension of our private practice. We really don't want to do that. We want to come to the podcast and feel like we're being part of the community and having conversations and coming from a place of knowledge and experience as opposed to just opinions, So that's why we have this podcast.
Yeah.
I'm excited. Let's introduce our first topic. So what is mental health? What is mental illness? One of the basic fundamental differences between the two, and we were just discussing this because even between Victoria and I, we were having questions about it, even though we know this because we have master's degree that made us really understand what it is. But in theory and in practice, it's really kind of gets all blurred together.
There's so many terms.
Lots of terms. And then with the media, and then, with celebrities and everybody coming out and saying, it gets confusing, and I don't blame people. But the easiest way to break it down is, mental health is like your physical health. We all have mental health just like we all have physical health. So it doesn't mean that your mental health is perfect all the time, because sometimes we wake up achy with our physical health, and that's the same thing that happens with us with our mental health. We have a bad week, a bad day, we have an issue and something that that's challenging that we're trying to overcome, and we really need some help with that, or some big major life issue, or the pandemic, things like that really get our mental health offline, and that's generally what everybody has to deal with. And some of us need help with that, some of us don't. It really enables us to understand how and why we're going to respond to the challenges that life throws at us. Now, with mental illness, we'll let Victoria talk about that a little bit. And as we go on in the conversation, we'll try to sort of tease that out. But basically, mental health, everyone has it. Not everyone has mental illness. But in mental health, can lead to mental illness if you don't take care of certain issues that you need to take care of. So, if you have an infection in your leg and you just kind of let it go, it's going to eventually go into the disease, type of mode with it. And you're going to have to get more serious with your doctors about it. And with mental health, you want to prevent that from happening. So it's a lot of prevention and intervention before you have to go into treatment.
Yeah, for sure. And mental illness, on the other hand, is an actual diagnosed disorder. So we have our DSM, which is the Diagnostic Statistic Manual. I almost forgot what that stood for because I haven't said it so
Number 5. Number 5.
Which is a list of mental health disorders. So someone might have issues with anxiety. Like Xiomara was saying, the pandemic has created anxiety in a lot of us, but maybe not necessarily to the point where you have a diagnosable anxiety disorder, because there are certain criteria or certain symptoms that you have to have in order to qualify for a mental illness. So I think moral of the story, everyone should be taking care of their mental health and their emotional health, their mental well-being, but not everyone necessarily qualifies for a mental illness.
Correct. And one of the things that, it makes me cringe is when I hear people having a bad day, going through a bad breakup and anything to that effect, and use the word depression the way that we would as clinicians use it, because for us it's a clinical term, and it's sort of been normalized in the community to use it when someone is going through a hard time. They're so depressed, they're so this and that, which is very different than having the clinical version of depression. That is an illness. It is a diagnosable illness. There are many symptoms and traits that are required to be met in order to be diagnosed with it. It's not something for people to just casually throw around and act like, they'll get over it and da-da-da, because it is an illness that people really have to manage and have to, and it can be severe. It can be, something that's a little bit more low key, but it's still there, and it affects the way a person responds to the world. It affects the way that they're able to manage their life. It affects the way they think and feel. For me, when I was going through regular everyday depression that we all have, I was able to do things to kind of get myself out of it, and, being a little overachiever that I am, and get myself out of my head. But when I was after 9/11 and I went through like some personal things because of surviving that, I couldn't do anything to get out of the depression. It just kept getting bigger and bigger and bigger and bigger. And I kept thinking it was just my regular old depression. And it turned out to be that, I had a medical trauma-based diagnosis for my depression, and I needed to get mental health people to help me. I had to go to my psychiatrist. I had to deal with medication. I had to really fight hard to get through it, over it, and past it, which thank God is behind me. But I've learned a lot about depression since then, because I was one of those people that just threw depression around, like, I'm depressed. But really, in reality, all my life I've had what they used to call dysthymia, which is now called, persistent depressive disorder. And I always managed to get over it. But there came a time when it was just a very serious illness, and I really needed to do something about it, because it affected everything. How I saw the world, how I, everything, my relationships, everything, how I ate, how I slept. It was very dysfunctional in terms of just trying to have a life.
Yeah, and I think that actually is a really good way to determine a tendency versus an actual illness, is that if you have a mental illness, it's affecting every domain of your life, like you're saying. It's affecting your career and your relationships, and you wake up feeling some type of way and you go to bed feeling some type of way. It's not situational, which I think makes a big difference.
Yeah. And the thing I want to make sure that we're making clear to everyone is that everybody has mental health. Like I said, not everybody has a mental illness. And just because you have mental illness doesn't mean you cannot have good mental health. It just means like if you have diabetes and you have to go to the doctor and you have to get your blood checked and you have to have your 3 month, every 3 months get checked and make sure that your lifestyle is what it needs to. Everything that sort of supports you being as healthy as you can with diabetes is the way that you have to deal with your mental illness. So if your mental illness is clinical depression, major depressive disorder, or something to that effect, there are very specific treatments that we as clinicians are taught that are evidence-based, which means science is behind it and it's proven that it works for most people. So if you're doing that, and you're working hard with something that's evidence-based to deal with your mental illness, there's no reason to think that you're not going to lead a productive, healthy, worthwhile life, because you will. You will be able to do that. It doesn't give you like a death sentence or anything like that, which is what most people are afraid of, that when they get diagnosed with something.
Yeah, I mean, illness, disorder, diagnosis, those are all really big words. And I think they can be really scary for people, whether in a physical or mental sense.
Yeah.
But so how do you know if you have a mental illness?
Well, again, I cringe when people try to self-diagnose. And with the internet, it has just become so prevalent for people to punch in their symptoms and these things pop up that they resonate with, and they automatically diagnose themselves with some mood disorder, some anxiety disorder. This is the big one now, is where people are diagnosing their significant others or family members with serious personality disorders based on some sort of ugly family history that they have. Suddenly, and these, the only people that should ever diagnose mental illness or deal with mental health issues are people who are licensed, who have their credentials, who are being clinically supervised, who are, have a board that they answer to, and everything along those lines, just like a doctor.
So not life coaches?
No, don't make me. Okay, that's personal. We're going to get into that in another episode. No, you shouldn't be. Listen, nobody should be diagnosing or treating for anything that's mental health or mental illness related, including trauma, including mood disorders, unless they have all the proper credentials. And that includes master's degrees and up. Yeah. It includes, certifications. It includes CEUs. It includes licensure, supervision, so many things which is why I cringe when people just decide that somebody has PTSD or somebody doesn't, based on whatever they've read on the internet and whatever classes they've gone to. And it's dangerous to do that. So I forgot your question.
I forgot my question.
Oh, how do you know if you have a mental illness? You only know that you have a mental illness if you go to the appropriate licensed professional mental health clinician, and they do the appropriate assessment. They do your diagnostic evaluation, which is what we do on our first session with everyone, right? Your first session is not about, talking or therapy or anything. We really sit there and go through a thorough intake and evaluation, and then go back and think some more and think. We don't diagnose right away. We meet with people, we talk with them, we get, collateral information, which means, what's going on with your relationships and your friends and all that, before we can say, and then the history. Because like in my case, like before, I had a history of depression. I never knew it. And it took a skilled psychiatrist to sit there and really take my whole entire life, history, and figure out, you have always had this. And you seem to have always been able to find that thing to get over and get past it. And now that coping mechanism is no longer working, which is why you're going into, so you need skilled, that's why they're there. So, that's why they're there. It's one thing to do like, self-help and all that kind of stuff that I have, I used to really be into that, but now I don't know. I kind of have issues with that too, but it is helpful. It can help people, but there's no way to diagnosing yourself. You go see somebody.
Yeah. Even if you are a mental health professional, I think it's really dangerous and easy to diagnose yourself. I mean, I think we're all a little bit guilty of that, to be honest. Especially going through graduate school.
Oh my God. Where you diagnose yourself with everything.
With everything. I had every new disorder.
It's just like doctors. I think I had that. But let's talk a little bit more about mental illness, because I think that's the thing where the stigma comes from, right? Yeah. So mental health in general is basically about, and I just want to reiterate this, is about your mental well-being, your physical and social well-being. Everybody has it. We all have moments of poor mental health, and then we want to do things to promote good mental health, and we go out there and do what we need to do, including counseling sessions and things like that. Mental illness is another thing. Say you have, and Victoria is going to talk about this, all your life you've had some sort of compulsion and you've never been aware of that. This is just my question. And you've always thought that that's just something that you did until it started interfering with your ability to live your life, or in some negative kind of way. We're just going to use obsessive compulsive disorder because that seems to be something everybody wants to say they have now. I'm so OCD because I have this, that, and the other. Okay, no, you're not, because you wouldn't even be able to know that you have. I mean, it would be such a thing. So now we're going to talk about mental illness. This is a mental illness that is in our DSM. Our DSM is basically like what the doctors use to diagnose their physical illnesses. The DSM is what mental health professionals use to diagnose mental illnesses. So we're going to just let Victoria talk about.
So with OCD, a lot of people have OCD tendencies, right? But in the DSM, it says if your tendencies are taking up to an hour of your time each day, then you might meet criteria for an obsessive compulsive disorder diagnosis.
Is that the minimum?
It's the minimum, 1 hour per day. And it also has to be pretty distressing.
Yeah. That is the key word, everyone. It's distress. It interferes in your ability to live your life in peace and normal functioning. It really creates a lot of dysfunction and distress for you. I mean, there's more to it than that, but that's generally when you need to start really paying attention to what's going on. What's an example? What's an example of something that can become OCD where we really are the ones that can come in and say, whoa, wait a minute, what's going on here?
Probably checking behaviors would be the easiest one to use. If you are checking to make sure your door is locked before you go to work, maybe once or twice, that's an OCD tendency, but it's not enough to be diagnosed as a disorder. Right. Let's say that you are checking your door 5 times each day and it's increasing more and more each time. And then let's say you check 5 times and go to work, but then your brain says, did you check the lock? And then you have to drive back and then you miss half a day at work. Right. It usually builds on top of each other. Yeah. So now you're missing work, you're impacting your relationships, you're spending time going back and forth to work. Yeah. It's very distressing. So I think something like that.
And so you can see how Victoria's sort of painting the picture of how that kind of behavior imposes upon someone's mental health. So that illness starts to encroach on your ability to be okay with, I locked it, I left, and it's not going to impact the rest of my day. And then the anxiety starts to creep up, and then your anxiety and your rumination and your thinking over and over, and it becomes intrusive in your brain, and all these kinds of things start to happen where your mental health is now being impacted.
Yeah. So and then you start checking more things, setting the coffee pot on. So it usually builds. And I think if anyone is curious, they should ask. You could schedule a session with a counselor or talk to your doctor about it and see what they think. So
and again, just to be very clear, coming into someone's office and saying, hey, I check my lock 12 times before I leave, and then I'm driving and I'm obsessing on that, it still requires someone who's skilled at giving you the appropriate screening for this, because perhaps there could be something in someone's life that's causing them to have anxiety, and this is how it's presenting. Mm-hmm. And then maybe getting to the root of what that anxiety is can sort of minimize and cause that behavior to sort of go back to normal. So that is why people should not be saying that they have OCD, because they're catching themselves doing repetitive behaviors. And I was in the military, so everything in my refrigerator needs to be dressed and in line and everything, because that just never went away. That does not mean that I am OCD. Mm-hmm. Do I have tendencies? Yeah, we all do. But it's not interfering with my ability to put my groceries in my refrigerator and put my things in there when I, that kind of thing.
Exactly.
And I don't flip out if somebody moves my milk and puts it behind my juice, and I don't, so that's it. You need to make sure that a professional is using the appropriate screening and doing the appropriate steps that they require before they diagnose you with something that's serious. And then let's talk a little bit about, okay, so what, you have a mental illness? Because here's the thing about getting diagnosed and people trying to diagnose each other who shouldn't be. Right, Victoria? We use it in our field as a language to talk to each other, to talk about what's going on with our clients so that we can provide appropriate treatment, so that we can have a language that makes sense to us, so that we can know, what steps to take and what's evidence-based and all that kind of stuff. It's not something that when we're in, hanging out, I don't know, at home, having dinner, that we kind of sit around and think, yeah, let's just use all these diagnoses and terms and whatever to sort of talk about everyday behavior. And there's a reason for that. It's meant for us to use, and it's meant for us to use it as a way to understand what is going on with different individuals in different ways, so that we can have a way to communicate and help the person deal with it. It's not meant to sort of be out there, like with everyone just kind of using these words, using these terms, using these really clinical terms in a way to describe what's going on with them without having the appropriate person guide them with that. That's where the stigma comes from. That's where the misunderstanding comes from. That's where we're antidepressants. We'll get into that. Like people just kind of start freaking out about the fact that they have the diagnosis, and that's it. They want nothing else to do with anything, because that is bad. That is bad that people are saying I have this.
Yeah. So I have a question for you. Mm-hmm. Do you always think it's beneficial to tell your clients what you've diagnosed them with?
That's one that I struggle with. Mm-hmm. I don't always diagnose everybody, because I have found in my practice that a lot of people come in thinking that they have these big scary things going on, that they need to be diagnosed and they need to be da-da-da. And in the end, after a few sessions, they tend to kind of resolve what they thought was the issue, and then they sort of go on to whatever is really kind of driving those behaviors that they were talking about. So if someone comes in and they're sort of presenting with depression and, and they're kind of explaining to me why, they're feeling depressed and what it's looking like and all that. After about 2 or 3 or 4 sessions, I can pretty much determine and do the diagnosis and all that about it. If they're still feeling like they're needing a diagnosis and they want a diagnosis, then I have an honest conversation with them about it. And, of course, I always check with my clinical supervisor. But I feel like if they want to know, of course, there's no secret, because if you go to a doctor and you want to know what the hell's wrong with you, you want the doctor to tell you. So, yeah, but I do it with a lot of psychoeducation. I do it with a lot of psychoeducation, explaining what this means. This doesn't mean that. This doesn't mean that. With antidepressants, if they're depressed and we determine that they are really clinically depressed and they need it, I really do this whole psychoeducation on how neuroscience plays a big role a lot of times in this. And in their particular case, perhaps antidepressants is what it requires with talk therapy in order for it to be resolved and it to go into remission. And are antidepressants happy pills, which is what they tend to think, that, oh, they're happy pills and they're just going to mask everything. And I explain to them, no, it isn't. That's why they're not street drugs. That's why people don't want them on the streets.
Not ecstasy.
Yeah, they don't just make you happy, And if you don't have clinical depression, they're not going to do anything for you, really. So, and if they do, it's all very clinical, and it's important to have a conversation about what that means with them. So to answer your question, yes, if they want to know. But a lot of it, when it's relational stuff, not really. If it's abuse and things like that, and it falls into the Z category, where it's about relational this and that. I don't really, because people don't want that. A lot of times they don't want it. If they ask me, yes, then I go through that. Or if I think it's beneficial for them to understand why I feel they have clinical anxiety, as opposed to just you have a lot of anxiety because you're dealing with da-da-da-da. And of course, like I try to have real open, honest conversations about that. What I don't like doing, and I stay away from doing, is just kind of throwing random guesses around. I don't know, like I've actually seen people, professional people do this and go, I don't know, maybe it could be bipolar disorder, or perhaps it might be a personality disorder. We're just going to have to wait and see. Like, don't do that. Don't do that to client. Like, as a client, I don't want someone doing that, because mental health clinicians also have mental health counselors. We
should. Yes. As we should.
Yeah. And I wouldn't want my person to sit there on the first day or the third day throwing around, 3 terms based on some random thing I said. Like, that's not how you diagnose me. Okay.
Yeah. I mean, then it kind of feels like they're just trying to put you in a box.
Yeah.
Which I've heard clients tell me before that they don't really want a diagnosis because they don't want to be put in a box, or they don't want to be labeled. For some group practices, especially ones that are taking insurance, sometimes you actually have to diagnose someone after the first hour session, which I've always thought was a bit unethical. But
at the very least, uncomfortable.
Of course, yeah. How am I supposed to listen to you for 50 minutes and then be able to tell you what, mental illness that you're struggling with? Because like you said, it takes a whole history.
Yeah, you really have to, it's something to take seriously. I wouldn't want to tell somebody to have cancer and really all they have is an, upset tummy that just requires something else. I think it's something to be careful about. And just to be clear with our listeners, one of the issues that we have, just because the mental health system in general, mental health care system in general, just like our physical health system, has issues. I mean, we have, has issues. So, for example, there are insurance, for example. I don't take insurance at the moment, and I have people that self-pay, and so therefore I don't have to diagnose, because I don't have to deal with an insurance company who's going to tell me what I need to diagnose somebody with, and that it has to be this mental illness or that mental illness in order for us to cover however many amount of sessions. However, with mental illness, if you don't have a diagnosis and you're trying to use your insurance, and they don't receive a diagnosis from us, from a mental health clinician, and by that I mean someone who they consider should be providing a diagnosis. Then what happens is they can kick it back and say, we don't cover this, so we don't cover that, and the person needs the help. They know they need to have insurance cover it because they don't have the means or the funds or anything to do it, and they're in crisis and they need medication and they need whatever it is that's going on with them. So you almost put in a position where you have to pick something that's the closest thing, like depression. They have major, whatever it is.
Adjustment disorder.
Yeah, adjustment disorder is a big one. So that the insurance company can provide the okay and the, so just like the physical health world, it does work that way. And group practices know that, and, Medicaid and Medicare and everything just works that way. So mental illness is just one of those things that we have to work real hard to make sure everyone has access to getting care for, regardless of their diagnosis.
Yeah, I think we should have a whole episode on diagnosing, honestly. Misdiagnosing.
Misdiagnosing, yeah.
It's a big thing,
Self-diagnosing and diagnosing your friends and family. And misdiagnosing by clinicians, professionals, like what's going on there. It becomes a pattern, right? Like everyone you're seeing has depression. Every single person you have, everyone that comes to, and is this what you're specializing in? Like, it makes me wonder, right?
Absolutely.
Do you specialize in this?
With OCD, I read a statistic that said that on average, people go to treatment for 17 years before getting an accurate diagnosis of OCD.
I believe that. I can, yeah.
It's usually seen as anxiety of some type.
Well, isn't it anxiety based?
It's anxiety based, but it's not an anxiety disorder.
Yeah,
it's a new little category now in the DSM. So
just like trauma based illnesses. No. All right. So we digress.
I have no idea where we are in this outline.
So we're gonna just throw the outline to the curb, and
I think we're on a whole new topic.
J-Rock is laughing at us over there, like, oh. But meanwhile, you see him bopping his head. Yeah.
I mean, one thing I definitely want to talk about before we end this episode is the question of whether a mental illness is curable.
Right. Yeah. So that's controversial.
Yeah. So I'd like you to go first.
I hesitate to answer this question.
This is why we're here.
This is why we're here. I think that there are people in our field who definitely fall into the category of, no, there are certain things that are not curable that people will have to live with for the rest of their life, and they will have to be on medication in order to be safe from others, healthy, happy. I believe that. I believe that that is the reality. I also believe that that doesn't apply to everybody. I think that there are some people, I think the biggest one that there's a lot of controversy around is borderline personality disorder right now, where there's a school of thought where, it's complex post-traumatic stress, and that's why it can be cured. And some people don't meet the criteria. This is how they like to use. They don't meet the criteria anymore, so therefore they are no longer BPD. I'm not one of these people that believe that for that particular personality disorder. I look at her scrunching her face over there.
No, I agree with you. Especially a personality disorder, I would argue, no, I don't think it's curable.
And if anyone, is wondering what that means, there's a category in the DSM of different cluster A, cluster B, cluster C, right? There's and they all deal with different personality disorders, and one is narcissistic personality disorder, borderline personality disorder, and I think one is avoidant personality. I mean, there's a whole bunch of different ones. Obsessive, there's a whole bunch of different ones, and they all have their own. And again, we all have traits for all of these kinds of things. It becomes a disorder when it absolutely disrupts your ability to live a life without all the disruption and all that stuff. So with BPD, for example, is just one of the most, unfortunately, when it first started and it first kind of came into recognition by mental health professionals, it sort of was misnamed, in my opinion. I don't really feel like that's, because it's an emotional dysregulation for real. I don't necessarily, the borderline part is supposed to be that these patients fell between being extremely neurotic and having psychosis, and that was where the borderline was with them.
I had no idea.
Yeah, and that's where so they called it borderline personality disorder, because it was so hard to figure out where these individuals really landed, because sometimes they were on that side, sometimes they were on this line, and so but now that there's so much more research and there's so much more science and there's so much people that are actually specializing in this and all this, and there's actually with what's it called? I forget what it's called, but there's a particular therapy that's out there that they use for
DBT.
Yeah, thank you. Yeah, that's very, very. It has a great rate of, the prognosis is very good when people have that. So anyway, so a lot of people, when they go through DBT and all that, suddenly they feel like they're no longer symptomatic. Finally, they feel like they've got this in the chrome, they clear it. But then, a year later, they're kind of sort of back into, because something triggered them or whatever. So I don't know that I believe that it can be cured. But, there are people that feel that it can and it does, and that there's a way and all that. And I'm not here to argue or to say yes or no about that. This is just purely my experience in it and my understanding of reading the literature and watching the experts speak on it and all that kind of stuff. I just think that there are certain mental illnesses, just like there are certain physical illnesses that for the rest of your life, you have to manage, you have to have medication, you have to have treatment, you have to, et cetera, and you will have a fulfilling life that can be not symptomatic,
Yeah.
And then there are others that maybe can be resolved. Yeah. So I'm going to get a lot of backlash on that one.
No, I believe that if someone is diagnosed with a mental illness, and I'm saying I believe because it's my opinion and I don't know if it's fact or not, but once someone is diagnosed with a mental illness, I do believe that you have that illness throughout your life. I do think that it can be managed to a point where you don't have any symptoms.
Yeah.
Which can look like a cure.
Yeah.
But I do think that there's always the vulnerability that it could come back. You know, I kind of look at it through the lens of addiction, where, you know, if you struggled with addiction, even if you're in recovery for 40, 50 years, you're working at that recovery, you know.
It's active. It's absolutely, yeah.
There's always a possibility that you could have a relapse. So I kind of look at it that way. I know that could sound discouraging to kind of say like, well, if it can't be cured, what's the point of even trying? But I also think in a way it is encouraging, because how many times do people experience mental illness and they do everything to treat it through therapy, medication, all the coping skills, all the self-care, all you know, and it comes back. Your symptoms come back, and then it's hard not to reflect that back on you. Well, what am I doing wrong? You're not doing anything wrong. You have an illness that you're struggling with, and you're having an off day. You know, so
and you know, and the thing to understand about mental illness is that there are symptoms involved. It's not just, oh, you're having a mood or you're going through a phase. There are very specific symptoms that are involved in every single mental illness that's in the DSM. And we as clinicians need to be very clear that you have however many of them you're supposed to have in order to be diagnosed. Some people don't like, they get to the point in their treatment or in their life where they no longer meet the criteria to be diagnosed with whatever it was that they were diagnosed with once upon a time. And that's wonderful, because that's what we all want, right? We want everybody to get there. You know, I want to get there. We want everybody to get there. But the danger in that, and this is what I hear a lot of people once they get there: I am now cured. I am no longer rather than saying I no longer meet, you know, the criteria to be diagnosed. And you know, it can work for some people and doesn't for others. It's just a sticky area, which is why, again, when it has to do with mental illness and mental health, I really want people to understand the difference between the two, so that you can focus so much more on, even if you have a mental illness that was diagnosed like me, right? I had clinical depression. Am I symptomatic? No. Do I get symptomatic sometimes? Yes. Do I need to be re-diagnosed officially with it every single time I have, you know, an episode that lasts a few days or 2 weeks? No, I don't. I don't need to go get re-diagnosed all over again with it, because guess what's going to happen? 2 weeks from then, when I start kind of like going through my self-care and doing all the things that I need to do medically and whatever, I'm no longer going to meet the criteria for clinical depression anymore. Yeah. So does that mean I don't have depression? You know, like, it can be tricky. So I think that for the average everyday person, I would encourage them to think less about what the hell the diagnosis is and why, and that, you know, that's more for clinicians to think about, because again, like I mentioned, that's their language that they use in order to try to provide the intervention and the treatment and all of that. For clients, what makes more sense to me is for them to understand their symptoms, to understand what helps, what doesn't, what's working for them, what isn't working for them. Am I in remission? Am I not in remission? Is this going to be all of, you know, everything for the rest of my life or not? Like, it's just for them. That's what I encourage them to learn more about, because that's what they have control over, you know, because we can change all the names in the DSM because that's what they want to do, right? With BPD and everything else, they want to call it emotional dysregulation. Listen, okay, but it's still the same symptoms. Even if we call it, you know, the happiness, whatever, it's still going to be the same symptoms. It doesn't change the symptoms, the behavior, you still have to do the same thing for the treatment part. So whatever you want to call it, I'm okay with it, you know, whatever.
So moral of the story, focus on the symptoms and not the diagnosis.
Focus on your symptoms, on getting to a place where you can be in good mental health. Because remember what we said at the beginning of the episode, that we all have mental health. We don't all have mental illness. And just because you have mental illness doesn't mean that you cannot have good mental health. You can. You know, just like if you end up with some sort of physical issue, you can still have good physical health. If you go and do everything that you need to do to take care of it, you can still go run your little marathon. Doesn't mean you can't do your, you know, thing and live your life. But you need to make sure that you're doing what you need to do to take care of that, you know. So And stigma is going to be something that we're going to be talking a lot about.
Of course.
Because that's really detrimental to people's good mental health.
Yeah.
So. All right. What do you think?
I have no idea how long we've been doing.
What to expect for next week's episode, I guess. First of all, I want to thank everybody for listening to our first episode and for having patience with us, because this is our very first one. This is our very first one. And I know that not everyone is going to agree with everything that we say, and that's perfectly fine, because that's what we want, is for everybody to have a place where they can, have a back and forth about these issues and, your opinions and facts and science and not whatever it is that we all need to talk about. It's a safe space for everybody to do that. Mm-hmm. What I do want to make clear, though, is that Victoria and I are really here to help everyone understand this very complicated world of mental health. And so in our first podcast, we're practicing how to do it so that we can make it, better and better for you guys. And we're definitely open to suggestions and what people want to hear and what people want us to talk about, and what your opinion is about what we just talked about. Because again, this is our opinion. We're just having a conversation about it, and that's it. Right, Victoria?
Right. Mm-hmm. And I like, like you said, conversation, because I don't want it to just be between you and I. Yeah. I would like it to be with everyone who's listening too, that they're a part of it as well.
Yeah, man. Let's have a conversation. So our next episode, Victoria is going to choose the subject for that, and she picked a really good one.
Yeah, so we're going to talk about 2020, our favorite year of all time, and how that year, more specifically the pandemic, even though a lot of stuff has been happening. But I think we're going to focus mostly on the pandemic and how that has been impacting mental health.
Yeah.
Because it's had a huge impact.
Right.
And we have lots of statistics that I want to share, because even I feel like I was unaware of the magnitude of the impact that the pandemic did have on mental health.
Right.
It's significant and
scary.
Yeah.
The big one that I've been reading a lot about lately is how it's impacted children and the youth. The major mental health implications that have come out of the pandemic for children and, the younger folks. So we're probably going to have that be a series, because it's just a lot to try to, you can see we can barely get through one episode, like episode 1, stay on the subject. So we're going to break it up into a series so that we can have a different issue for the pandemic for as long as we're all interested in that.
Good idea.
Okay, so I want to thank everybody for hanging out with us and listening to our conversation. We really appreciate your support. We appreciate being here, and we're hoping that this can be something that everyone will benefit from, and that it'll grow into something that makes more sense for everyone listening, and that it'll be something that everybody will tune into and have their opinions about, but mostly that they come away with something. Even if they disagree or don't understand or whatever, they could go and talk to their own mental health person and say, I heard these 2 people talking about this, and have an open conversation about it with your family, your friends, your significant other, your mental health provider, your regular, providers, and make it, normalize it. How that's chic to say now, right? Normalize it.
You're so hip.
Yeah, so hip. All right, so then we're gonna sign off.
Awesome. Thank you. That was fun.
All right. Okay, we'll see you next week, everyone.
Bye. Hey everyone, Victoria here. Thanks for listening to Studio Talk. We hope you enjoyed our conversation into all things related to mental health. As always, you can head over to Studio Talk on YouTube or on Xiomara's website at thex-studio.org, where you can click on the podcast tab on the top menu. Sign up for our email list is there, as well as check out all the links and resources, including Xiomara's website, in the show notes. That's all for this episode, and we hope to see you next time. If you are experiencing any psychological distress, please call 911 or go to your nearest emergency room.